Thank you for joining us, everyone. We're delighted that you're here. This is a collaborative community conversation with PCBH-SIG. We're delighted that they are bringing this information to share today, and we have a number of folks that are going to be leading us in that conversation. I'm going to turn it over to my community conversation co-facilitator, Corey Knight, for a few words, and then we'll get things started.
Yeah, thanks, Tanya. Well, good morning, good afternoon, good evening, wherever you are. Welcome to our monthly community conversation. We're so privileged to be partnering up with the PCBH-SIG and really hearing about some of these great outcomes that they've been looking at in terms of like workforce development, and just really hearing about some of these exciting findings. As part of our community conversations, we really do encourage feedback from those of you in the audience today. I will be monitoring the chat as we go through. I usually leave it up to the presenters if they want to pause and take questions or save them to the end. It's really up to you all, but please feel free to engage, ask questions. We want this to be just have a really kind of conversational feel. So with that, I'll turn it over to you all.
Great, thank you so much, Tanya and Corey. And we absolutely agree with Corey saying we want this to be a conversation, and we'll share a little bit of data and the background of the survey that we did last fall. And then we want lots of time for discussion and for feedback from people who are attending today who are interested in the topic. So I'm going to start sharing my slides, but while I do that, I'll introduce myself and then introduce the two other team members that are here with me today, or pass it to them to self-introduce. So my name is Kelly Bozak. I'm a licensed clinical social worker, and I'm a BHC and a co-director of integrated behavioral health on the Southern Oregon coast. And I was formerly a co-chair of the PCBH-SIG, and now I'm working with the Measurement-Based Care Workgroup for this work that we're sharing with you today. And so I'm going to pass it over to Dave so he can introduce himself.
Thank you. Hi, I'm Dave Haddock. I am the president of a company called Psych-Analytics. We provided the technology for the survey that some of you experienced in Boise at the convention. And it's my colleague, Stan, who's next to me on my screen. He did the programming work and the data analysis for us. And now I'm being joined by my cat. Sorry about that. So anyway, her tail might be in the picture for occasionally, but anytime I sit down, I have a lap cat. So I'm participating in the work group for outcomes. I'm also participating. My first contact with these groups was with the Research and Education Committee, and now I'm involved with PCBH and the Value-Based Payment group, because all of these different groups really fit together. And I think because I'm not a clinician, they all seem to make sense to me to be merged. So, pardon me. So anyway, I'm anxious to get on with this and to hear the feedback, and we have a lot to learn today. So we're most happy to get started. Megan?
Hello, everyone. I'm Megan Fondo. I am here in Madison, Wisconsin at Access Community Health Centers, and I am been a part of this group, which has been a very fun group to be part of, and came to it through the PCBH-SIG as well, serving as the member at large last year with Kelly and this year as well. Looking forward to talking to you guys. I'll be taking notes today, so if you see my head swiveling, that's what I'm doing. Thanks, everybody.
Thanks, Megan. And we have about 4 other people who have been in part of the group since we started last summer. And so they weren't able to be here today, but their imprint is all over the summary and the data that we will review together. And so we give lots of credit and kudos to them for their historical and ongoing support. And we're excited to welcome new people into the fold so we can keep working on this. And then we're going to start off with sharing a couple of slides. So I'm pulling up that presentation. And let's bring it to a slideshow. All right, so most recently, we've mentioned the words PCBH-SIG and Measurement-Based Care Workgroup. Most recently, we've become a separate work group outside of the Primary Care Behavioral Health SIG, but we originally emerged out of the PCBH-SIG. I'll talk a little bit about that context in a moment. So really excited for this community conversation. At the end of our hour, we will talk give some reminders about how to become involved in this work ongoing, but we recognize that some people may not be able to stay the whole time. And so you can always reach out to Tanya, Corey, or anyone in CFHA to connect with us, or you can always email me directly and Hannah can help you get in contact with our group or our base camp where we keep all of our work together as well. And so we're just going to talk about the survey that we built and administered and then reviewed the data for in the last 3 months of 2022, as well as the executive summary. And Dave has some of the raw data to share with everyone. And then we have some follow-up questions that we want to share and invite everyone who's here today to give feedback about when it comes to screening, as well as measurement-based care in terms of outcomes measurement and how your health centers or your practices are thinking about this in integrated health settings. And then towards the end, we'll talk about, as the work group, what focus we have for the next 6 to 12 months within our work and how to get involved if you're interested in what that charter is starting to entail. All right, so a little bit of the history really quickly. In spring of last year, so about a year ago, CFHA CEO Neftali approached the PCBH SIG with a really just delightful invitation and comment to help begin the work of catalyzing standardized outcomes for measuring success in the PCBH environment. So that was a really wonderful invitation for us to shine a light on the area of primary care behavioral health work and how that is being implemented, what the barriers are to implementation. And we see a lot of conversation on the CFHA discussion groups and listserv and at conferences about how do we track and know that what we're doing is working, and how do we weave that into our funding, into our value-based payments, into our training of clinicians, kind of all the elements of integrated care. So we started meeting as a small work group, just a couple of people coming together, had a couple of meetings to discuss how to fill the PCBH measurement gap. And first we wanted to tackle the question of what screening is actually, what is the difference between screening and outcomes measurement? And so that's a discussion that we continue to have and want to have with you too. But we first want to understand, what are people doing? What are they screening with? What are any barriers to screening? Because that will be the first step in implementing any type of tracking of outcomes, using tools and having those integrated in your practices and workflows. So our survey, this is a breakdown of the executive summary that we released in January of this year. And again, it includes the purpose of the work group, as well as to report on our first phase of the screening and assessments measurements that were reported to us by CFHA members or attendees at the CFHA conference last fall in Boise. So the methods that we used, we created a survey that was constructed by our small work group, about 4 to 5 people, to just learn what PCBH screening tools are being used by CFHA members. And this was an open invitation that we shared in multiple avenues at the conference and through the listserv around the conference time. So it was about a period of 4 to 6 weeks that we were advertising the survey, and it was open. And we gave lots of QR code handouts at the conference. If you remember those, we put it up on slides, and we blasted on the listserv several times as well. So we put out over 200 invitations to invite people to fill it out. And again, lots of announcements were made. And so I'm going to pass it over to Dave now, just to look at some of the raw data from what we got back.
Thank you, Kelly. I would like to start by describing how we presented the survey to the respondents. It was all done on cell phones. The QR code would link you to our data center, and we would display the screens with sets of questions. The sets were organized by domains, and such as you can see on this screen: chronic pain, bipolar disorder, cognitive function. I just clipped a bit out of the big long table. We had a total of 16 domains that we queried, and we selected 4 to 6 screeners that were familiar to our group that we thought would be illustrative of what we're looking for and give people a quick ability just to click a radio button and identify a screener that they were using. We at the very last moment, we realized we should put in some sort of a free text field. So we had a line at the bottom of each of our domains that said other measures you use. And so it was really amazing to see how many people took the time on their phone to type in the names of their favorite screeners. And some of these names are quite long, and some people did many more than one. So what I put the arrow here to show you that there was one respondent in bipolar disorder who used something called the rapid mood screener. In chronic pain, there were 8 people that used this whole list of other screeners here that's shown in this table. And then for cognitive function, there were 6 people that asserted that they like to use these screeners. The little green highlight shows the dominant screener in that selection. Next slide, please. Kelly?
Sorry, 1 second. Okay. There we go. Sorry.
Okay. So we had 108 respondents, and you can see on this chart that depression screening is 94% in place. Anxiety, 89%, substance use, 78%. We learned after we looked at the results that pediatrics deserved its own unique survey because 80% or 80 out of 108, 74% of the people who responded, and now 90% were clinicians or directors of behavioral health. And 74% of those did pediatric screening as well as adult screening. So that was pretty impressive. And it means that people are being very flexible and using different screeners for different populations. So this is the top number of screeners used. These are the domains that we screened for. Okay. So in each domain, people identified a screener or not. So if they identified a screener in that domain that went into this tally, you think respondents dropped off at the bottom with quality of life, global health profile, eating disorders, and mania. We turned that data around and looked at the screeners not used. We had a checkbox that said, I don't screen for this domain. So they could either leave the whole thing blank, which we interpret as they don't do screening, but we didn't want to leave it as a guesswork. So we said, tell me if you don't screen in this domain. So quality of life, as you saw on the other side of the page, 60 people do not screen. This is kind of the inverse of the chart to the left. When we get down to depression, everybody screens for depression. Next slide. So we tallied up the screeners that were most prevalent in each domain. This is the domain list, alphabetical, showing the half a dozen domains which are very popular amongst the respondents. And you can see that in ADHD, 28 people used the ASRS. In anxiety, 96 people used the GAD-7. For bipolar, 46 people used the MDQ, and so on. And then here's depression, where you would expect to see the PHQ-9 very high. And the Columbia Suicide Severity Rating Scale is being used in conjunction with the depression screeners. Under substance use, we have audit and DAST dominating. So this gives an idea of the data we have by domain as to which are the most popular screeners. Popularity is probably a wrong connotation. Maybe most useful screeners would be better. We looked at the logistics of screening, and you can see upon arrival or before arrival, 20% did screening. While in the waiting room, 32%, during the appointment, 38%, and upon completion of treatment, 6%. Now, these will never add up to 100 because people click 2 or 3 different places where they do screening. Another cut we could have made was, how many people screen at multiple times. But you'll see, if we're looking for outcomes, only 6% are doing any kind of screening, any formal screening with a tool after the patient's completed their course of care. So that sort of says nobody's looking at outcomes. The data on the other slide, where there's very little use of quality of life or global health score, these are all conceivably roadblocks as we move forward into value-based payment, because we don't have a culture of measuring the outcome in a way that can be reported statistically. And so we asked one question explicitly: do you screen for outcomes? And 51 people said no, but 42 said yes. Now, so we didn't really unpack what that yes answer meant, because most people didn't touch quality of life, global health score, and screening after the end of treatment. And yet 42 people said they screened for outcomes. So we don't know why that is. Okay. Last slide, please. Oh, second to last slide, sorry. These are what I call the favorite screeners across all domains. You can see the GAD-7, the PHQ-9, audit, and DAST. These are the top screeners just by use. So these are the screeners most people are familiar with using. On the other side of the page, we have the same data from the pediatrics side. And here the PHQ-A is top rated. Now remember, there were 80 people who responded as doing pediatric screening, but only 55 were using the PHQ-A, 51 were using the Vanderbilt, ASQ, and so on. But again, top 6 screeners are pretty commonly used, just like over here, the top 10 screeners. So there is the potential to leverage the familiarity people have with screeners. Next slide. And I think that will lead us into the possibility of creating a standard set of screeners that we can recommend. Because if we do the same screening in different clinics, then we can start pulling the data together across these different silos and start looking at our population statistics, our geographic statistics, and so on. Okay, so we ask people if they are measuring their readiness to do screening. Okay. And so 48 people said they don't use any kind of a readiness screening. This is readiness for PCBH or integrated behavioral health care. And so you can see the numbers, they drop off very fast. There's very little internal assessment, okay, of whether the clinic is either having fidelity to the model or looking inward to see if they're optimizing their integrated care and so on. And then finally over here, we at least personally, I promote computerized screening so that we take the workload off the clinicians. And in this very long survey, I think we had 65 potential answers, something like that. The majority of people were able to run through this screening tool in 2 to 4 minutes. So they were able to read, interpret, respond, and type in free text entries, all in the space of, say, 2 to 5 minutes. So it sort of shows that if we automate screening, it can be done quickly, and we can take that load off the staff and presumably acquire more data with less effort and help us present the outcomes of behavioral health to the value-based payment people. Because and as we've been discussing in all these other groups I'm part of, a behavioral health outcome is not the same as a medical outcome. And it represents a long-term relationship. So we have to somehow value that and show it's different and equally worthwhile as a medical outcome. So thank you, Kelly. That's the end of that little presentation. We have lots more data. If anybody wants to see the whole report, just let me know.
Yeah, absolutely. Thanks, Dave. I'm really grateful you were able to pull some of that data so we could look at it. I'll just highlight a couple of things from the summary, and then we'll break and see if anybody has any questions about the survey or data before, and as we lead into a broader discussion. But Dave summarized most of what is on this slide and the next two slides in his review of the data. For instance, just the percentage of respondents who were direct clinicians, BHCs, BH directors, or trainees. Most people or many people are not screening for outcomes, and that there's such a wide variety, a very broad range of tools, screening tools that are being used in the clinic, and very little in terms of measuring outcomes or repeated screening. The other observations, let me just pull up the next one. Oops. Lots of screening in pediatrics. And what's so interesting too about working in, and I'd be curious to hear others' experience as well, so much pressure on the screening and limited training on what are benchmarks, how do we continue to measure, and what screening is really appropriate to my setting and my patient population, and what's really meaningful to the work of the primary care team is something that I think a lot of us get caught up in as well. So some suggestions that we have going forward are to continue to gather information about how frequent people are screening and what methods of measurement they're using in terms of through their EHRs, pen and paper, self-service portals, tablets, or cell phones prior to or during an appointment. We are also really working on continuing to prepare to maybe hopefully launch another survey that also incorporates nuances around value-based payment and further defines measurement-based care, which is really important to us. And we want us to consider how we can increase the use of global health, quality of life, social determinants of health as potential outcome measurements that really represent the integration of behavioral health and social determinants of health in the healthcare setting. We'll love to work collaboratively with the Research Evaluation Committee and other work groups in CFHA to make a recommendation for clinicians around how do you help select a menu of screeners to train your integrated team on or your primary care teams on to help normalize data analysis and review of the data, similar to parallel models of care like collaborative care model. And well as to promote policy development to reimburse for outcomes measurement, and to support the use of long-term data collection and normalize the use of data in behavioral health care. So I'm going to pause and stop sharing and just see if anyone has any questions for Dave, myself, or Megan about the survey data, or impressions. Yeah. If we are, I'll give it like 30 more seconds. If not, we will shift to some specific questions we have that we would like to prompt conversation around. And I'll bring up some slides. So, and you can feel free to ask any specific questions about the survey moving forward as well. So we'll bring up, so the first question that we have, and I'll share my screen again, is around the challenges that you may face in administering screening of behavioral health issues, global health, and functioning in your setting. So essentially, what are the biggest barriers that you face in administering the screening? I've also put on here, sorry, one second. Okay, a QR code. So we have a Mentimeter up. And so if you would like to, you can type them in the chat like Corey said, or if you want to do it on a Mentimeter, we can also show it in a presentation style. And so that can also be a really fun way of compiling it for us as well. So I would recommend, if you can, trying to use the QR code, or you can just unmute and share what challenges you're facing. These are really great. A lot around time, a lot around consistency, which probably relates to time. Oh yeah, even the time to pick the measures, buy-in from the care team, knowing which screeners have the most research to support their effective use and frequency for completing the screenings. Absolutely. Yes, simply having the staffing for data entry or a data entry platform infrastructure, limited resources, or even many limitations can be within the EHR that your organization uses.
One comment that's in the chat too is not automated for telehealth visits as well. So I
Oh,
wanted to
yeah.
add that.
Oh, absolutely. Definitely. Great.
Yeah, this raises questions about the usefulness of data that we may acquire over time. If people are only screening as part of their therapy, the patient's already been selected. And so the selection process of who gets care is not really addressed. If screening is implemented on a routine basis, then the case finding would be entirely different, I believe. And there's a study from UCSF about forcing the MAs to screen the PHQ-2 for 100% of the patients. They translated into all the languages that come through the clinic. Changed dramatically the people who received care from before and after. Why don't we go on to the next question?
That's great.
This is really clever. I like it.
Okay. All right. So the next one is, what successes have you had have you accomplished? Sorry about that extra in administering screening or outcomes tracking of behavioral health outcomes in your setting? Gaining buy-in from the care team, making the time to review the measures with patients. Absolutely. I'm curious if for the individual who wrote in buy-in from care team, if there's anything you want to share about, if you want to unmute and share how you accomplished that.
That was for me. This is Megan, and I think we did a few different things when we started doing more broad screening across adults, where we tried to give data back to the care team weekly for a while to be like, here's what we're learning, here's what we're learning, here's what we're learning, and this is how it's helping, and tried to have some stories about how it helped. We started doing screening for alcohol use, for example, and a provider who was very skeptical about having all these screeners because it's just so much paper and it's just so much trouble and it's just blah, 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 right? Too many things they're already doing. Had found that an older adult who was having multiple falls had actually been having the equivalent of several cocktails every night, and didn't realize how much she was having. The provider didn't, the patient didn't, nobody realized it. The screening helped to identify it. She cut back and she'd stopped falling so much. So, it was a pretty dramatic and direct way to give feedback back to the care team. I will say that's been hard to maintain that level of feedback.
Mm-hmm.
So having the staff to help maintain that is also important.
Mm-hmm.
That's a chronic condition. We start out with these great programs, and then 2 or 3 years later, they're gone. It takes a lot of energy to sustain a particular workflow, especially if it's not being paid for. Now, in the future, where value-based payments are, we hope, more prevalent and there's less fee-for-service work going on, these outcome measures will become important, because that will be the corner of the realm for the practice surviving financially. So those workflows will have to be sustained.
Mhm. I'm curious if the individual who wrote the time to review the measures with patients, if you'd be able to share how you do that. If you're able to unmute, or feel free to write in the chat if you can't. I really appreciate that one. Why it's highlighted for me as well. I've seen a lot with training new BHCs or helping with either new graduates who are still under supervision, or those who are shifting from another specialty who are already licensed, that the shift to the medical setting where it's really normalized to review lab results or review outcomes with a patient in a medical appointment, that reorienting a BHC to do the same, to really utilize the environment, the context of when we come to the clinic, we meet you here as a person, but that we also review data at the same time, is really essential with helping clinicians to structure their sessions and even to help orient the patient to the process. And then by doing that, I've had some patients ask, I didn't get that screener this month, Kelly, or I forgot it, or can we still do that? Or what did I get last time? Am I improving? So it can certainly start to help, and even you can utilize different parts of whatever outcome measure or screening that you're using to set certain goals or start formulating interventions.
That reminds me of a very funny episode early in the work with my company. As you know, most of the people here are involved with Medicaid clinics, but we did a beta test in a very much middle-class, white, suburban primary care clinic. And when we surveyed people coming in to the clinic before they saw the physician. And the response we got from some people was just hilarious. They said, at last, I get to tell the doctor something I want to tell him. So they're obviously they've been frustrated by the lack of two-way communication in their interaction with the PCP. So the fact that your people said, hey, where's my screener?
Right.
That's just wonderful. They want to give you feedback. They want to measure their own results.
Exactly.
And just to touch on in the chat too, somebody had mentioned that this is a great tool for recovery. So reviewing the screening measures, looking at the changes over time, comparing goals, and then moments in recovery. So really kind of approaching this from another angle and really how it can be useful, especially for those in recovery or in the process of it.
Mm-hmm.
And there's, Corey, there's another aspect to recovery. People who are in recovery are at risk every time they go to the doctor or the dentist, because that information is embargoed. So it's not readily available to the clinician or the dentist even. So if we do screening, then we can learn that information about the patient. We can be more circumspect and more careful about how we treat them with analgesic agents.
Yeah, excellent point, Dave. Thank you.
Mm-hmm. All right. So we're going to shift some other questions away from the Mentimeter, but I'll pull them up. Did not totally mean to stop sharing. Okay, we'll go back to this. So the next thing that we want to hear as well, and part of our kind of what we hope to start spurring is the sense of who is at the table when we're deciding what outcomes are being measured and who has input on the selection and the administration of the instruments and outcomes. So we want to invite you all, and this will be more versus the Mentimeter versus in the chat, or just unmuting and sharing with us too. What level of involvement do you have, or what healthcare team members are deciding what tools you use? You can be as specific as possible. or really as specific or general as possible?
I just want to say the audience is everything. Always consider your audience as the first rule of making a presentation. And so when clinicians want to do more screening, how do they have to present it? What kind of motivators do they have to use for the different audiences that get involved?
So the first comment we have is BHC's medical director or clinical director.
Mhm.
Yeah, I can add at my site. It's definitely been a mix of BHCs and director types. The other factor that's been a huge one for us is our electronic health record and what's in there. We went through the process of getting something added that we wanted added that wasn't already in there, and it took years to get it added. I mean, it was a long process. So that's kind of the practicality side, if it's already in Epic, that tends to guide people's choices, whether they think it's the best measure or not, if it's already there and it's accessible.
I don't know if anybody watched Dave Bauman's number 49 PCBH Corner with Dr. Kessler. He was very, very blunt about saying that the PHQ-9 is useless. It would help 20 years ago, but now it doesn't tell us anything. And so that is the problem with EHRs. They're looking back years into the past. And it's very hard to create a learning environment if you have to wait years to get a new screener put on. How do you experiment? Well, there's a new world of technology thanks to the 21st Century Cures Act, where third-party software vendors can work alongside EHRs. And by law, the EHRs have to interoperate with those other software packages to absorb the data that they generate. Not widely available in practice yet, but it's coming. And it will change the way we think about working with EHRs. And we're talking about serious legal penalties for not complying with interoperability and making it easy.
Yeah.
So.
Thanks, Dave. I'm going to move us to our next question. But feel free to keep adding any comments in the chat. And we're curious if anyone in their use of screening or outcome measures has started to set any benchmarks. We're pretty familiar, a lot of us are familiar with some of the benchmarks that are set in collaborative care or COCM, especially around depression and readministration of the PHQ. Has anyone started to set benchmarks for readministering screening? A lot of you have mentioned about annual universal screening, but how about for readministering once you've identified a positive screen?
Yeah. Well, that's exactly what our data showed.
Yeah, and so Leslie wrote in there, and typically once a year, and there might be a flag on a chart for readministering. Yeah, some specific BH may use for monitoring.
Any clinician is doing that reassessment every time you see the patient. Okay, so it probably seems even silly or a time waster to do a formal rescreening or a formal reassessment. But we need the data, folks. We aren't going to be able to get our fair share of resources under value-based payments without learning to document the improvements and to define what an improvement is. So the silence on this question is very important. Or I should say it's very significant because it points to what we have to do in our work to recommend best practices.
I'll just note, I do think that a lot of practices are utilizing them as far as monitoring and symptom severity, and then using them in psychoeducation and with their patient populations. But then that's not systematically implemented, right? What isn't systematically implemented would be more of the requirements related to typically, payees and formerly known as UPSTFP. And so then we're going to have that minimum of 6 months to a year. So typically, if they have been identified, they have to do it again within 6 months. So that's part of the requirement for almost every screening tool. A minimum of 1 year related to things like SDOH, unless, again, it's been identified, and then you have to do it again within 6 months to show demonstration of impact related to measurements and for reporting. So those things are systematic, so that's why I didn't put all that in the chat, but I think those things are, I don't know how stereotypical that is, but most of the clinics that I know and I've worked with and my own, we have tried to implement that systematically. I can tell you that people fall off all the time. They get busy. The flags still remain. Then we do a dive every month. Hey, all these patients that we're seeing didn't get it, it's a constant work, but so are mammograms, right? So are colonoscopies, so are HIV, STI screening, so is vaccination rates. And those continue in the same exact format as these, as far as the challenge. I haven't seen at the centers where, hey, we have, everybody's getting their mammograms now. Over and above what we typically have. And, we notified everyone. It's the same systematic process problems we have with doing anything in healthcare. That people are burnt out, overworked, underpaid. The majority of our staff is who do this, not our providers. So just making that awareness, and then the majority of our providers have other pressures that they are required to do, right? And these things fall because we're not giving them the time to do it. If we did, and we appreciated that more, then it would switch for all healthcare maintenance and all screening. But we know that's still problems, right? Same with, if we want to target some of the things that were just announced and more of our great maternity care that we have in the US, birth rates, right? Woo, we do so great work with that. It's the same problems. They're continually to be highlighted, the same reasons. So I'm just trying to also normalize, right? So a balance of that is there. I do think there's the systematic piece, but again, it falls. And then how hard is it for us to be able to do it anyway when we're managers and leaders doing 30 million other things and prioritizing just general evidence-based care to be delivered at least once a day? Sorry to say, but right, everybody knows, oh my gosh, can't believe we did what, right? So the same pressures we all have, not to negate its importance, right? And like Dave said, we do need to be doing this, absolutely, but I think it falls into that consistently, and that's I think a global hardship when I see it, and even for myself, right? To do it, so.
Oh, absolutely. That was incredible too, just connecting it to that larger context of healthcare, and that we're all swimming in that same soup of screening for anything, colorectal screening, mammograms, all of this as well. Yeah. Cool. So we want to wrap up our conversation too. Our final question is really about anything else that you'd like us to know. And so I'll stop sharing just so that we can have more of an open conversation in the last 10 or 15 minutes or 10 minutes about what you're curious about knowing in terms of measurement-based care. That's really a part of our charter moving forward, is to help CFHA and CFHA members to further understand and connect with the standardized definition of measurement-based care, and to help work collaboratively with the REC and the value-based payment workgroup, which Leslie's with too, to help empower, educate, and invite clinicians into this realm so that they can make an impact and help join the flow of healthcare into the measurement-based care world and value-based payment, so that we don't, as a matter of retention, engagement, and training of the workforce too. We'll open the floor. Anything you all want us to know or be thinking about, or things that you're thinking about when it comes to measurement-based care? Yes, Isaiah. I really appreciate your comment in the chat too. So what you asked, what outcomes should we be trying to measure with screeners? Improve functionality versus decrease in symptom scores. Sure, this differs depending on the screener we are focusing on. Absolutely.
That is the key question.
Yeah, this is absolutely the key question.
Functionality is a great indicator of a turnaround in mood. But we're not using it. There's only one really well-founded tool, and that's the promise profiles, as opposed to the promise clinical tools. But the promise profiles in either the 29 or the 57 question version has only 2 mood check-ins, depression and anxiety, and it has 5 other ways to evaluate productivity, mobility, functionality in general. And it's, I think out of 100 people who responded, we had 1 person mention promise. So there's a great tool, free, easy to use, and nobody's using it. So I don't know where we're going to go with this functionality and how to embrace it as a quality metric, a performance metric, efficacy metric, whatever you want to call it. But reversal of symptoms is important, but that could just be learning how to take the test. Functionality is more concrete. Can you go to the store? Can you carry your grocery bags up the stairs? These are pretty objective metrics, and I'd like to see more of them, but I don't know where to go with that at the moment.
Yeah. And what I entered in the chat were based on a meeting we recently had with a couple of other key informants and people who are interested in measurement-based care work group, is trying to bring together some work that other organizations are doing on measurement-based care. So you'll see I put in some examples of operational definitions of measurement-based care. So one comes from a recent article in the Family Systems and Health Journal from 2023 about advocating for it, as well as it's helping to educate around the phases of collect, share, and act that are a part of utilizing measurement-based care. The APA has a measurement-based care work group that they are really, so the American Psychological Association, as opposed to psychiatric, they have a great website that has some resources on it as well. And they're meeting regularly and issuing reports and guidance to psychologists around measurement-based care and the utilization in practice. So they're really trying to promote data-informed, patient-centered care. So they're also grappling with this idea of symptoms, functioning, and how do we do that across all of the specialties that BHCs, that psychologists, that mental health clinicians work in, that the setting is going to involve all of these interrelated and complex issues. It's not just a clinic with depression or anxiety or OCD, but we're going to be utilizing measures for a variety of issues that show up in the integrated context. The last one that I put in there is from the Yale Measurement-Based Care Collaborative. They also have an operational definition and lots of resources and research that they're doing at Yale University, which is really interesting as well. So patient-reported outcome measures are the types of data that they're using to track progress and inform treatment decisions. As well. So interesting resources that we're looking at, that we wanted to make sure that we're sharing with you in case you want to do some research on your own or continue to help support our work too in CFHA in promoting ongoing discussion and support for directors, BHCs, healthcare leaders, or future administrators who are working in this avenue, because we are going to be hearing so much more about it as well. Different payers are coming saying, what is that? What improvements are you seeing in your behavioral health team in terms of continuing to pay and credential, whether or not it's fee for service or value based? So this is going to be making a difference further, more and more down the line. Yeah, and thanks Corey too for sharing a couple of other measures. The Duke Health Profile and the WHO Quality of Life Brief Measurement are great for measuring functioning. Absolutely.
One thing I would note is that the functional screeners and the social determinants of health screeners tend to be longer than the screeners that are being used in diagnosis or therapy. So it's another barrier. You need more information. There's only one way to get it. Let's ask more questions.
Hey, Leslie.
Yeah, the only other thing I will say is, I think the reason why we're not doing it as much, I always encourage people like functioning. That's what we want. That's what we need, right? That's the basis of us being here, not necessarily symptomatology change, right? And especially as Dave said, and especially if you're having any populations that have serious or persistent mental illness, you're going to expect, and they will continue to have symptoms, right? It is their functioning that you're really changing and improving. And that's what we also know is a key element to overall success in life and all these other things. So it is really important, yet those aren't the ones that are built into our EHRs yet. It's so horrible because I've used the Duke, I've used the quality brief. The quality I think is easier than the Duke. The Duke just has that math. Like anybody else uses the Duke, it, like you're like, I have to align the graphs and the scale, like it just, it's just not as easy. And it probably just takes 2 minutes longer than something else, which isn't a lot, but I always find it, that's the problem. But if they were incorporated more, then I think we would be at a better place. There is a lot of movement within the United States to incorporate them. So Medicare has approved specific quality measures and they've aligned them with payment, but they are very specific. So it's like the Veterans RAND something. So they name it. It's like Medicare Health. Sure, I'm going to say it wrong. And so I'm like, sorry, it's like the HOS, Health Outcome Survey or Health something. I don't want to say it wrong, but you can Google Medicare HOS and I bet you it'll come up right in the links. You'll have to follow a trail, but they are encouraging this and requiring it for Medicare Advantage programs and specific ones. And I think the more we have that, like where we have the purchasers and the payers saying, okay, we're going to do it, and here's the ones we will, then hopefully the EHRs catch up. Because as soon as they do, I think it'll be so much easier because it's very difficult to then have paper everything and then you scan it. You can't easily be able to see differences with that. We all know that the challenges with it. So I won't go into it, but I think that's the other problem. But I agree. I'd rather be doing those. Screeners help identify, right? And so great, we need population health and risk stratification and treatment interventions, et cetera. But we need to be focused on data-driven outcomes and being data-driven providers when it comes to that, and functioning is essential. So I agree on that part.
Excellent. Yes. Thank you so much, everyone. So I'm going to put my email in the chat. So if you are interested in joining the MBC work group, we are solidifying our next meeting, which will likely be one of a Friday in June. I just got an email from Hannah to finalize that date, so that information will be coming out. If you would like to join us and continue to even contribute to the conversation, attend our meetings informally, or be kind of a regular participant who's taking on some of the work or the products that we're trying to share with the community, please reach out. We're happy to have you, happy to grow, and we welcome people of all levels of literacy with measurement-based care, of outcomes measurement. Even if you have just know that there's the ocean out there but never been there, we're willing to help get you there, and we learn together. That's the only way we'll make progress on this. And so anyone, whether or not you're an expert or a novice, we're here for you, and we'd love to have you work with us too. We think that's helpful for what we share to help reach the broadest community possible. So feel free to send me an email and we'll get you all connected. And we just thank everyone who participated in the survey, who showed up today and gave us your feedback as well. And we hope that you have a really wonderful Wednesday.
Thank you, Kelly.
Everyone.
Yeah, thanks everybody.
Thank you all for your inputs.
Yeah.